What happens to chronic low back pain patients when referred to chiropractors from spine surgeons? Chiropractors often lament that patients don't come to them first prior to seeing a surgeon. The literature does in fact indicate that patients seeing a chiropractor first are far less likely to have spine surgery. Yet there is some distrust from spine surgeons. Some believe that the cases they see are potentially more serious and complicated, and therefore are not going to respond to chiropractic care. What if this perception could be changed culturally? What if a chiropractic program existed at a state-funded university, and chiropractic was included as an academic medical discipline? What if chiropractic students completed a Bachelor of Medicine degree in parallel to chiropractic specialty courses prior to entering the chiropractic program? And what if chiropractic students completed a 6-month internship at a teaching clinic that's affiliated with an orthopedic university hospital with a large spine division? And most importantly, what if spine surgeons referred appropriate patients directly to the chiropractor? Well, welcome to Switzerland. The chiropractic program in Switzerland evolved differently from that in the U.S. There are 5 academic medical disciplines in Switzerland: medicine, dentistry, veterinary medicine, pharmacology, and chiropractic medicine. The chiropractic program is part of what is called the Faculty of Medicine at the University of Zurich. Chiropractic students complete a Bachelor of Medicine degree in parallel to chiropractic specialty courses before they enter the chiropractic master program. Chiropractic students complete a 6-month internship in a teaching clinic that is affiliated with a university hospital with a large spine division. And most importantly, spine surgeons refer patients directly to the chiropractor. This provides a wonderful opportunity to study a different relationship between spine surgeons and chiropractors whose education is a shared experience. It allows both for a shared discussion and a viable option for the spine surgeon. This relationship is the basis for the study that we'll review. The title of the publication is An Observational Study on Trajectories and Outcomes of Chronic Low Back Pain Patients Referred from a Spine Surgery Division for Chiropractic Treatment, published in Chiropractic and Manual Therapies in 2019. The unique population studied are patients who have been seen by a spine surgeon and who are then referred to a chiropractor for their turn at management. And we'll see this population is not like that seen in general practice, but is a concentrated cohort of patients who generally have tried other options and have chronic, non-responsive low back pain. So who are the patients? 67 patients with chronic low back pain were referred from spine surgeons to the chiropractic teaching clinic. The majority of the patients, 46, had experienced low back pain for more than 1 year. The remaining 21 experienced pain for more than 3 months, but less than 12 months. 12 patients had previously undergone back surgery. The MRI on 31 patients showed degenerative changes such as disc degeneration and stenosis. These patients were combined into a category called nonspecific low back pain, together with 14 patients whose MRIs did not show any abnormal signs. Further pathologies were radiculopathy in 5 patients, spondylolisthesis in 3 patients, and osteoporosis in 2 patients. For 52%, the treating chiropractor judged their general health as good, for 41% average, and for 8% poor. The median of the number of chiropractic consultations was 8, with 3 patients treated more than 20 times. Most patients completed the chiropractic treatment within 6 months. After 3 months, 43% of the patients were still being treated, and after 6 months, 21%. And look at the variety of prior care. In the prior year, 4 patients had received injections, 38 patients had undergone physiotherapy, 4 had received massage therapy, 2 received, quote, complementary medical treatments, and 6 had received multidisciplinary therapy. During the study period, there was concomitant care. For 13 patients who reported other therapies at the time of chiropractic care, physiotherapy was used by 10 and massage therapy by 3. 13 reported having stopped other therapies, and no information about current therapy status was available for the remaining patients. Outcome measures were standard approaches using the numerical rating scale for present pain intensity and the Bournemouth questionnaire, a biopsychosocial outcome measure with a maximum score of 70 points, which was measured at baseline and after 1 week, 1, 3, 6, and 12 months, and the Patient Global Impression of Change scale measured at all time points except for baseline. So let's get to the results. The NRS for present pain and the Bournemouth questionnaire total score for biopsychosocial impairment decreased by about 25% within the first 12 months after the start of chiropractic treatment. The Bournemouth total score showed significant reduction within 1 month, while present pain intensity took 6 months before improvement was apparent. Most Bournemouth questionnaire items significantly improved within the first month, except for the item ability to take part in recreational, social, and family activities, which did not improve at all, and the item depression that did not improve until around 3 months. Improvement of single Bournemouth questionnaire items varied between 18% for anxiety and 32% for own ability to control back pain. The observed overall improvement on the Patient Global Impression of Change, reported as better or much better from 1 month onwards, was reported by approximately half the patients and was associated with a significant reduction in biopsychosocial impairment. The proportion of patients reporting overall improvement significantly increased from 23% in the first week to 47% in the first month, 56% at 3 and 6 months, but this reduced to 44% after 1 year. Overall improvement was not associated with reduction in pain, but with biopsychosocial impairment improvement beginning at 1 month after the start of chiropractic treatment. Let's look at the relationship of pain to rating of overall health and its relationship to the Bournemouth questionnaire measure of biopsychosocial health. Pain intensity seemed to contribute less to their rating of overall improvement than intuitively assumed, which is in accordance with previous literature. Quote, in contrast, the total reduction in biopsychosocial impairment seemed to account for the self-perceived overall improvement in this population of chronic pain patients. Interestingly, this was not attributable to a single Bournemouth questionnaire item, unquote. Although it was not associated with overall improvement, average pain over the last week, the first Bournemouth questionnaire item, significantly improved within the first month of treatment. Note, the average pain over the last week and present pain decreased by 29% and 25% respectively within the year after the start of chiropractic treatment. And although this doesn't quite reach the usual percentage for a minimal clinically important change, it's rather close. And as we saw, perhaps pain reduction isn't the main determinant for improvement in this chronic patient group. Noteworthy, though, is that even after 1 year when chiropractic treatment had been terminated, pain intensity for this chronic patient population stayed significantly reduced, on average, for 80% of the patients. The researchers note that because patients were referred by spine surgeons, on average, they had more severe pain and had higher biopsychosocial impairment. This was evident when compared to previous data from a private practice study's results in Switzerland. Comparatively, patients were in worse health, as indicated by their own impression. More patients had low back pain lasting for longer than 1 year, 70% in the current study versus 45% in usual practice. And a higher proportion of patients were taking pain medication at baseline, 35% in the current study versus 28% in usual practice. Unfortunately, not described but extremely important is the answer to the question, what were the referral criteria used by the surgeons? If one was developed and utilized, it would be a valuable tool for U.S. spine surgeons. And if it was not an algorithmic approach, was it a conferral with the chiropractor and mutual agreement on referral? The answer is not evident from the publication description. So in summary, although we don't know the criteria used and we don't know what would happen with a comparison or control group, this study certainly points in the direction of suggesting that if a working relationship could be established earlier on in training with spine surgeons and some guidance on criteria for referral were established, A significant number of patients referred to spine surgeons who had failed other care might benefit from a course of chiropractic care. Here we see the layout and sequence of the chiropractic medicine program in Zurich. So the question arises, is the referral relationship illustrated by this study the consequence of a shared educational experience and working environment? This culture of shared training carries with it a potential shift in public views of cultural authority normally held by MDs only. If so, the U.S. will be hard-pressed to forge a cultural change that will be as meaningful to providers as a shared educational experience. And given the variety of approaches to chiropractic education by different institutions in the U.S., the uniformity provided by the educational criteria for the MDs and DZs in Switzerland is unlikely to be accomplished, so that surgeons' attitudes to referral will remain on an individual-to-individual experience and decision. Perhaps in the U.S., the VA system and some entrees into an association with university systems will emulate the working relationships seen in Switzerland and nurture the strength of relationship catalyzed by a shared experience.